Hey folks, Professor Finn here, and today we're going to be looking at Chapter 12 of Embalming History, Theory, and Practice by Sharon Gee-Mascarello. Let's go ahead and get started. Alright, so injection and drainage techniques. Let's get the pen set up. So arterial embalming has two primary functions: the injection of the preservative solution and the drainage of blood and other fluids from the blood vascular system. A total of 4 distinct processes are actually occurring simultaneously during arterial embalming. The first is the injection of the embalming solution from the embalming machine into the artery, the distribution of the embalming solution throughout the blood vascular system, the diffusion of the embalming solution into the cells and tissues of the body, and finally, the drainage of the contents of that blood vascular system. Now, the proper selection of vessels and corresponding injection and drainage methods is critical to achieve uniform preservation and sanitation. So we don't do these things one at a time. They're happening all at the same time. We select the proper artery, we start injecting, we start pushing the fluid into the empty spaces of the vasculature that are devoid of blood. We finally encounter those areas, we start pushing those things away. As we get into the capillaries, we start having that lawn sprinkler effect where the preservative distributes into the cells and preservation takes place. And then, depending on your theory of injection, you will start pushing the contents out as drainage, or you may wait a little bit before you actually open up and take drainage, thus charging the system or filling the system even more with preservative solution and building up intravascular pressure. So by using the ideal vessels and methods, you will ensure that a sufficient volume of embalming solution is delivered and retained in the tissues. You'll have adequate drainage, which will remove blood discolorations, edema, and cellular waste to some extent, in some cases better than others. A proper moisture balance is established to prevent tissue dehydration, and the appearance of the deceased is acceptable. So first up, we have what's known as a one-point injection. A one-point injection uses the same site for both arterial injection and blood drainage. The same site injection and drainage is suitable when the embalmer anticipates uncomplicated distribution of embalming solution and favorable blood drainage. The way that I suggest my students learn this is you have a finger for injection, you have a finger for drainage. Okay? And when you are given a scenario and it says you are injecting here, you're draining here, take your fingers and put them in those positions, which means you have to know where these arteries are. So if you don't have these arteries cold, go back to the chapter, look at the arteries again, get into your anatomy book, pull out the color plate of the vascular system, highlight the common injection points, the neck, the legs, the hips, whatever it's going to be, and point to those things. And if your fingers are in the same place, that is a one-point injection. The other important factor here is the word uncomplicated. What is uncomplicated? Something that is not complicated. So a normal case. The body has very little time between notification of death and arriving at the funeral home. Very little time has elapsed from reception of the deceased to beginning of preservation. And at time of embalming analysis, there is not any factors which we will study in depth as we progress in this course that would trigger maybe an alternative to a one-point injection. There are embalmers who pride themselves on one-pointing everything, and that is fine. Okay, and if that is a mark of honor for yourself as an embalmer, then by all means, wear it proudly. But when it comes to scrutiny, when this is brought into the jurisdiction of the courts, and we are looking at, did you do something smart, did you do something right? Using a one-point injection on a case that may call for something different will be one of those areas where scrutiny will be applied. It is simple as that. Be able to justify what you did, why you did it that way, and what the results were. This method is customarily selected as the primary injection technique. If I can do it from one spot, it's going to save me time from doing other places. and I only have one incision to have to worry about leakage from. The method selected for incising the artery will determine whether both arterial tubes can be placed simultaneously into that artery. So we're going back to the wedge cuts, we're going back to whatever your favorite cut is going to be, whether it's the transverse, the parallel, etc. Me, personally, I did not, as a matter of habit, put both tubes in at the same exact time. Inserting an arterial tube into both directions was not something that was a high priority for me. I know for other embalmers that is different. The most frequently selected vessels for a 1-point are going to be the largest arteries we can access on the adult human body, which is the right common carotid artery, the right internal jugular vein, and then the femorals, followed lastly by the armpits. Now, when we talk about, hey, these are the three most common, these are the three most common. So if someone is citing this for a test question, this specific reference, it is the femoral arteries, the carotid with jugular, and the axillaries. That being said, the way I encourage you to remember this in case one of these things is missing is neck, hip or legs, and then the armpits. And the reason why I say hip or legs is because, especially in obese individuals, you are substituting the iliac arteries for the femoral arteries. So the moral of the story is you want something in that upper leg, if not right at the hip where it becomes the iliac. You want the neck or you want the armpits. So the left common carotid artery is often raised as a secondary site to supplement the injection of solution and or clear blood discolorations from the left side of the face. The left internal jugular vein is also raised as a secondary drainage site. And when you start raising other vessels, this now becomes a multi-point injection. So we're going to be looking at multi-point here in a second, as well as a split injection. Those are two different things, and we'll talk about them. So one important thing about the left common carotid. The left common carotid, the reason why it's not a preferred is because the left internal jugular does not drain directly into the heart. So if we put in a drainage instrument, angular spring forceps, a drain tube, what will happen is you'll place it in and it will not go into the heart and keep the valve open, okay? So you cannot get the type of drainage that you would get from the right internal jugular, and that is one of the major reasons why this is considered a secondary point of injection. Descriptions of how to do these 1-point injections are listed in the book. You can read them on your own time. One thing that people seem to forget about this is that the book is not intended just to be a textbook reference for class. Your embalming book should be one of those books that you keep indefinitely for the duration of your career. At any point, you can take your book, open it up, go to a page, and literally follow the numbers. And the textbook will give you absolutely a step-by-step process on how to achieve sufficient preservation for the case that you are looking at. It is not just meant for a book study and then you forget about it. And people that suggest that that is the way the book should be handled simply don't know enough about it. Now, what are the big disadvantages? There are pros, there are cons for every one of these injection styles. Well, the biggest disadvantage, arguably the biggest disadvantage, is short-circuiting of arterial solution. Embalming solution, any liquid, tends to follow the most direct route of point of injection. Liquids follow a path of least resistance through the arterioles and the capillaries and the venules to exit as drainage. This can account for a great amount of arterial solution loss. Short-circuiting can be decreased by restricting drainage to create intravascular pressure. Long story short, going into the path of least resistance. Skin has a greater presence of capillaries compared to the deeper body tissues. Squeezing fluid into those small spaces is much more difficult than filling the large pipes. So what's going to happen is your body is going to fill the largest spaces first. the paths of least resistance. And then it's going to start pushing into other areas where it takes a bit more effort. The result of having greater presence of capillaries is that the skin surrounding the injection site can easily swell when over-embalmed. If you're injecting here the entire time, it is going to circulate in this area the longest. By the time it gets into the legs, depending on your injection style, the pressures, your technique, you may have sufficient embalming while embalming is just beginning, preservation is just beginning in the outer extremities, which will result in an over-preservation of the upper area. So injection from a more distant site is warranted when the neck and facial features are affected. Short-circuiting and paths of least resistance cause embalming solution to reach only the skin and the superficial tissues. Shell embalming is the result of inadequate preservation to the deeper tissues. So now we have something called shell embalming that is associated with short-circuiting. So what is happening is if you have blockages especially, you'll just recirculate in the same exact area. You'll start getting all sorts of nice color, but what you're not getting is anything underlying actually preserving. The way I describe this is basically the 30-minute marinade, right? If you take a object to be marinated, tofu, meat, whatever it might be, and you take it and you drop it into a marinade, and you take it out after 30 minutes, and then you prepare it for consumption, you're going to have flavor on the outside, nothing on the inside. What do we have to do? We have to prepare that product accordingly, adding extra holes, letting it sit longer, etc. That is the embalming equivalent of, that is the food equivalent of shell embalming. You're getting a very surface preservation, nothing inside. So what you want to do is you want to make sure that you are filling and you are pushing to the outside, not just recirculating in the same place, thus causing good color with nothing else getting anywhere. This can also be triggered by an overuse of dyes, where you are putting in, you see lots of color, and you're like, hey, this is taking it great. Well, embalming is an art. You have to compare what you're seeing to how much you've injected and your strengths of your solutions. All these things come into play, and that's the skill you gain with experience as an embalmer. Tissue massage combined with manipulation of extremities and restriction of drainage will encourage movement of arterial solution into the muscles and deep tissues to prevent shell embalming. There are different schools of thought on massage during embalming. There are some people that do it every single time. There are people that don't do it. There are some that encourage very deep and rough massage. There are others that don't. All I can tell you is you do which one you are comfortable with. Multi-point injection. Multiple injection is the injection from two or more sites. An additional site or multiple sites is identified to supplement the primary injection site when arterial solution cannot reach a particular area or when an area is insufficiently preserved. Suitable arteries are located closer to the area sufficiently embalmed. So, in this case, we are looking at an autopsied torso, right? We have this wide open area, which means we're going to have to inject the shoulders, we're going to have to inject the neck, we're going to have to inject the legs. If possible, if we can find the internal iliacs, we're going to want to inject the deep tissues of the back. More than likely, we're going to be stuck with hypotrocaring, those sort of things, or hypodermically injecting, or using a hypovalve trocar to inject preservative. And that is the moral of the story. When you start using the fingers, that you are pointing to one artery and then another artery, another artery, another artery. Multi-point. The moment you go from one place to one place plus another, you are now looking at a multi-point injection technique. So what are the advantages? Injection from multiple points increases the overall effectiveness of the embalming. Each additional site is used to inject a specific region or section, called sectional embalming. Military regulations require the use of multiple sites for long-term preservation. In the 5th edition of the textbook, if you go to chapter 25, it talks about the military style of injection in detail. Multi-point injection is recommended to address lengthy post-mortem time intervals between death and embalming, in between embalming and funeral rites, in between embalming and final disposition. Fancy way of saying, when is multi-point recommended? When one point isn't correct, period. One point is not suggested. So there are time delays in any one of these areas. You have any complicating condition such as edema, etc., stuff like that. So when should you use a 1 point? Normal case, no complicating factors. When should you use multi-point? When you have complicating factors or large time delays. And it says here, the use of multiple injection sites is beneficial in the following conditions. And the one thing you can take away from all of these is that they are complications. Right? If it was normal, you wouldn't have any of these. So there are people out there that will memorize every single one of these checklists. But if you're looking at everything you see here, every one of these is simply a complicating factor. You just have to know that these are complicating factors. It's that simple. So a 6-point injection. This is a type of multi-point. A 6-point injection isolates each extremity, both arms, both legs, and both sides of the head. Embalming following a complete autopsy, cranial and trunk, is an example of a 6-point injection. Now, typically, again, we are looking at something to inject each one of the lower limbs. On paper, is it a femoral? Probably not if it is hanging inside of the torso. The femoral does not start until after you pass the hip and start getting into the leg. So what you are likely injecting at that point is the external femoral. It is very important that you grasp the concept very quickly, that it's both arms, both legs in some way, shape, or form, either through the iliacs or the femorals, and both sides of the neck. A 6-point injection is also used for non-autopsied cases. A lot of people say, well, that's an autopsy protocol. It's not just an autopsy protocol. It can be used on any single case. It is time-consuming, and to most embalmers, the criteria of their worth, of their skill, is getting it done and getting it done quickly. This is something that is persistent in old-school embalmers. There is nothing wrong with getting it done quickly and efficiently. There is a problem when you are quick and efficient, but you are not thorough, which then necessitates time taken for subsequent injections. So the moral of the story in embalming, folks, really should be do it right the first time and take what time you need to do it right the first time. The anticipation of embalming challenges such as poor distribution of solution, incomplete blood drainage, increased probability of tissue distension, fancy way of saying swelling. Okay, whenever you see the word distension, just think in your mind it's swelling, because that's what it is. And lengthy post-mortem delays validates 6-point embalming. Now, another benefit of 6-point injection is that you could use a different solution in each region. This is especially important because decomposition may not be uniform throughout the body. That's usually the case. You'll have complications in one area of the body, but not in the other. Well, again, let's go back to a food analogy. You are out at a restaurant, and you order a burger with 2 sides, and you choose to get fries, and you choose to get broccoli. And your food comes out, your burger is perfect, everything is exactly the way it wants, that you want it. You look at your fries, they're hot, they're crispy, they're great. You look at your broccoli, and it's very clear they put this through a microwave and it's still cold. What are your options? Having worked in food service, I can speak a little bit to what options people have selected. So the first option is you refuse the entire plate like a dumbass, and then you go ahead and you make them redo everything. Not very popular with the waitstaff, just saying. Your second option is to critique the one thing that isn't working and go get a replacement for that. Right? Good. That is the embalming equivalent of using different solutions, different products on different areas of the body that need it. If you have a body that has a problem with one leg, and you can very clearly see that there is a blockage and you have discoloration and it looks like it might even be going into the early stages of decomposition, and the rest of the body is fine, in your professional judgment as an embalmer, your analysis could start with, okay, what I am going to do is I am going to raise a femoral artery. Okay, I'm going to raise that leg, and I am going to inject towards the heart a normal solution, a moderate solution. 18 to 22, 23 index, normal concentration of 2%, and I should be fine because the body itself is in good condition. Now with the leg, I could inject a 2.5 to 3% solution. I can use something like trauma care or Intrafiant to address the complication I see in the leg. Instead of injecting the entire body with trauma care or Intrafiant, which may be too strong for the entire body and start dehydrating and cause other complications. Now, I know embalmers out there are going to be, you could just go ahead and use that and add some humectant to the Intrafiant. Yes, I know that. From a student perspective, the moral of the story here is you use the right thing for the right job. And if the body is normal, especially when it comes to professional testing, the expectation is that you understand you can use normal on one thing and then the complicated solution for the complicating factor. When we get to professional practice, we can talk about how we can moderate some of these solutions so they're not as harsh, absolutely. But that is not likely something that is going to be assessed on an entry-level competency examination. Customarily, the extremities of the body are injected prior to the head. So when you are doing a 6-point, the way to kind of remember this is start at the bottom and work your way up. Legs, arms, head. Now, some will do arms and then legs. Some will do arms and legs at the same time using a double Y tube or a double Y injection apparatus. Hey, knock yourself out. The moral of the story is that you save the head for last. Now, when the right side of the face is the most visible, viewable side, the left side is injected before the right side. The order of injection allows the embalmer to make adjustments prior to injecting the most visible side of the face. The order of injection is based upon professional judgment. Nothing here states that this is the only way it gets done. The recommendation is that you start with the extremities, work on the head. If you are assessed, you will absolutely need to answer. You start with the extremities and then go to the head. Why? Collateral circulation. When you are injecting, there are lots of different avenues that your solution can take to get someplace. And what you will find is sometimes things will sneak into areas you are not injecting because of the abnormalities of that particular body. So for instance, in the legs and the arms, that's not really a big deal. But in the head, when we are injecting the left side, the typically non-visible side, right? If we have trauma, we can position the body facing straight ahead with no angle, and we have where we're focusing over here. So we start injecting here. If there is an issue, if we realize that we have immediate swelling, if we realize that we can't be using our solution, we can then stop what we're doing before we come to this side. And above all else, as we are injecting here, some of it may come over here through collateral circulation. And if it does, good for us. That's a quarter of the job that's already done. But the moral of the story is you start in the non-visible sides and then you get to the visible side. You start in the non-visible areas, the legs, the arms, and then you move up to the head. That is especially true if you have a generalized condition throughout the entire body and you want to see how that solution is working. You start in the legs. If it works great there, move on to the arms. If it doesn't, adjust before you move to the arms. By the time you're done the arms, you should know if that solution is working or if you need to tweak it one more time. The chronology for a 6-point for an autopsy is identical to non-autopsy cases. There is no difference between autopsy versus non-autopsy. A 6-point is a 6-point. Start in the legs, go to the arms, left side, right side. Now, split injection. Split injection is the injection of solution from one site with drainage from a different site. This method reduces short-circuiting of the arterial solution and establishes a uniform distribution of the arterial solution. The most frequently used combination of vessels in the split injection method is the right internal jugular vein and the right femoral artery. Now, there are a lot of people that say this is a waste of time. You're having to make 2 cuts. You should just start with a 1. If you need to go, then you're going multi-point. They're not wrong. Okay? When I started my career, I did 1-point injections, and I was taught through my preceptors that really, if you know what you're doing, you shouldn't have to do much more than a 1-point injection unless you have a really bad case, at which point you should probably do a multi-point, no ifs, ands, or buts. After years of teaching clinicals, at my previous employer in a school embalming lab, I started experimenting more and more and more with the split injection technique. And what I can tell you, in my experience, my preferred way to inject is a split injection technique for the reasons it states here. So, how do we differentiate a split injection from a multi-point when it comes to our fingers? And it's simple. You have one artery, you have one vein wherever it is. That is the difference between a multi-point and a split. Your fingers will not be in the same place, but once you point to where they are, that is the only place they stay. So for instance, 1-point injection. I raise the left common carotid, the left internal jugular. 1-point injection. Split point injection. I raise the right common carotid artery with the left internal jugular vein. Professor Finn, that seems a bit ridiculous because you just said the left internal jugular vein doesn't have the beneficial qualities of raising of the right internal, where it goes right into the heart. Correct. It is absolutely ridiculous to do something like this. But it's permissible on paper to see if you know what a split injection is. It doesn't have to be, quote-unquote, right. It just has to demonstrate, do you know what a split injection is? The more appropriate way to do this would be you raise the left internal, or the left carotid, common carotid, with the right internal jugular. Why would you do that? I don't know. I literally don't know why you would do that. But if I was asking a test question, this might be something that I do because no one would ever suggest this at a funeral home. If I raise the left femoral with the right internal jugular, split injection. Multi-point. I raise the right internal jugular and the left internal femoral, followed by the right internal, or the right external femoral, or the right femoral to the left femoral. I now have a multi-point injection. It started as a split, and the moment I move to another artery, I have gone to a multi-point. A split injection is a 1-point injection using one place for drainage, one place for injection. The most common is you inject with a leg and you drain at the right internal jugular. Under a theory of split injection, realistically, actual practicality, it is because you want to make use of the right internal jugular for drainage and some other injection point. And as we get into the split injection, you'll see why. Choice of a single site of injection can lead to the split injection method when drainage is difficult to establish. For example, the initial site of injection is the right femoral artery and right femoral vein. When inadequate drainage is recognized, the right internal jugular vein is resolved to poor drainage. So when we talk about injection, think about the word injection. We're not injecting into a vein. Veins don't count. I can drain from as many veins as I want. Okay, this is another concept people have trouble with. If I'm raising another vein, that is not another injection site. Split injection is most valuable for enhancing facial features during arterial embalming. Injection from the right femoral artery directed towards the head allows solution to distribute simultaneously through both left and right common carotid arteries. The injection pressure is slowed by the distance between the injection site and the head. The result is a gradual and symmetrical contouring of the face. Additional feature enhancement using a hypodermic syringe and a needle may not be necessary after embalming. This is my preferred way to embalm. Take drainage from the internal jugular, right internal jugular, and inject via the right femoral artery for precisely this reason. So you are injecting from the leg, fluid is coming up and hits the arch of the aorta, right? And then starts going into both sides of the head relatively simultaneously. Because remember, it's going to fill the larger spaces before it starts going into the smaller spaces. So things are going to creep into the head on a fairly uniform basis if there is no blockages. What's the problem here? If there is a clot or something somewhere in the body, you are pushing it right towards the head, and this is the warning sign with it. This is the big red flag. You do not want to use this if you are anticipating lots of clots, because of the fact you may block something in the head and now you're really screwed. There are ways you can mitigate that risk. And the easiest way to mitigate that risk is low rate of flow. Let time, okay, give time for the fluid to get where it's going by creeping around things and not pushing things off because of high rates of flow. Restricted cervical. Restricted cervical injection effectively controls or restricts the volume of arterial solution entering the head and face. Restricted cervical injection is the primary embalming technique practiced by a large number of embalmers. I do not feel that that is a qualified statement, me personally, but I am going to defer to the judgment of the person who wrote this chapter or edited this chapter solely because I have no way to refute it. I just feel that that might be a personal opinion. And the restricted cervical method is a standard at many establishments. I am not denying that it might be a standard at some establishments. Don't know about many. And the reason for a restricted cervical really is because it controls everything going into the head, right? You are essentially isolating the head from the rest of the body, and you have complete control so that you are even restricting, for the most part, collateral circulation. It will still happen in some cases. Don't be surprised that you do restricted cervical, you're injecting it normally, and all of a sudden you'll see color getting into a head. That's just something weird about that particular case. And the most common incision used for restricted cervical is, again, the semilunar incision. The restricted cervical method affords the greatest control over entry of arterial solution into the head because the tubes that are directed towards the head remain open while the trunk is injected. Excess solution that reaches the face and head via the collateral circulation routes will drain from the carotid arteries through the open arterial tubes. Reduces the risk of swelling, does not eliminate it. You still have to pay attention when you're doing this. The method prevents facial distension and dehydration when large volumes of strong solution are required to meet the preservative demands in the trunk of the body. This is important. An ideal time to use restricted cervical is when you have to use two different solutions, something stronger in the body, less stringent for the head, something stronger for the head, less stringent for the body, or you're going to go crazy with the body and you want to control color or something else into the head. There are lots of reasons why you would want to keep the head separated. Generally, it's because you are using extremely strong stuff to address something that's going on in the body. But again, depending on how a body is laying, if blood is pooling into the head, you're having lots of discoloration and swelling because fluid is going to flow from the chest into the head. If the body is lying straight down, you may have all sorts of problems, and your body will not necessitate the level of strength that you are putting into the head. So what are the advantages? The carotid arteries are large. They're very elastic. They have no branches. They have the largest veins, and they are rarely sclerotic. So let's talk real quick about what we're looking at with a restricted cervical. You're raising arteries 1 and 2 here in the head, okay? You're inserting a tube into each one of the arteries going north towards the head. You're tying off or opening up, okay? You're tying off and opening up your left common carotid, and then you inject going this way. So what is happening? Here's my arch of the aorta. Here is I should add, we're just going to pretend I didn't do this here. We'll add the left subclavian there. So here is my right common carotid. Here is my left common carotid. And what I am doing is I am opening a hole. I'm putting a tube in so that stuff can drip out. And then I am tying this off. I am inserting a tube going into the head. So again, things can leak out if I get collateral circulation. And now I am injecting into the arch of the aorta. And what happens is I fill all this, right? I fill all of this. I get to the blockage. Nothing flows into that head. And then it flows into the rest of the body. So I have essentially isolated the head from the rest of the body except for collateral circulation. And if I do get any collateral circulation coming off of this left subclavian, then it's going to hopefully come out the open hole. The advantages of restricted cervical closely mirror the advantages of injecting via the right common carotid. Any clots or coagula will be pushed away from the head. That's the same as using any one of the neck arteries to push stuff away. Embalming solution can be directed exclusively towards either the trunk or the head, and it allows the best control over the volume of arterial solution entering the head. 2 strengths of solution can be used, one for the trunk and another for the head. Again, this is, from a larger perspective, it's the same advantage of a multi-point injection. 2 rates of flow can be used, one for the trunk, another for the head, which you should be doing anyways, because the head has smaller arteries. You don't have to push all the way down to your feet. 2 pressures can be used, one for the head, another for the trunk. Large volumes of solution can be injected into the trunk without overinjecting, swelling, or dehydrating facial features. Features may be set after the trunk is both embalmed and aspirated, especially with the occurrence of purge during injection. So it then goes into the step-by-step, as I have already kind of told you. Raise the right common carotid and insert an arterial tube directly towards the trunk of the body. That's this one right here, and you can see it's got one of these really nice stainless steel quick connects. Insert a tube towards the right side of the head and leave the stopcock open. Now, in this case, there is no stopcocks present. So, I remembered this time. And brought out the old embalming kit. So, what I have here, what I'm going to do is I am going to go to full screen very quickly, is here is an arterial tube, straight arterial tube, threaded at the end, and here is my stopcock. So what I'm going to do, and this would not be appropriate for neck use, this is way too long. This is probably something you'd want to use for a leg. What I'm going to do is I'm going to place this into my head. I'm going to leave my stopcock open so that stuff can leak out. If I needed to close it, I could. That is why we use stopcocks. So in this case, what are we looking at? Well, all that they're doing is they have essentially put the arterial tube in and just left the bottom open so it can drip out. Serves the same thing. The moral of the story is you want that end of the arterial tube completely unobstructed. You insert your drainage instrument into the right internal jugular vein directed towards the heart. Raise the left common carotid artery and insert an arterial tube directed towards the left side of the head, and then you close the lower portion. So like you see here, we've inserted the tube going up, right? It's wide open at the bottom. Again, no stopcock. They're just using the quick release and leaving it open. But look what we have here. We have locking forceps. And you can see that they are clamped over the bottom portion of that artery. Now, one of the things that I saw in a Facebook group the other day, why would you ever make one of these huge incisions? Well, this is why. Look at it. You can see everything you're getting into. You can see that here's the lower portion of the right common carotid artery. That's probably at that point. You're looking at the common as it's going back towards the arch of the aorta, and just off to the side there is no drainage in there, but you can clearly see what looks like the right internal jugular vein. Inject the trunk of the body first. Drainage is taken from the right internal jugular vein. Solution entering the head by collateral circulation exits through the two open stopcocks. Only the trunk of the body is embalmed. And the good news is, if you're getting collateral circulation, you're probably getting a little bit of preservation up there, which, again, with restricted cervical, it's not an excuse for you to ignore what is going on. It is not an excuse for you to ignore what's going on and just go about your merry way. You have to pay attention because there may be a blockage. You could encounter swelling in the face. Inject the left side of the head, right side of the head. So after you're done the body, it's assuming that the body is adequately preserved, and now you focus on the head, least visible to most visible. The technique allows the embalmer great control over the amount of arterial solution entering the head. It's going to say that a lot. It allows large volumes of fluid, increased pressures, faster rates of flow to be used for embalming the body, trunk, and limbs without over-injection of the head. And again, I always caution people when they start talking about faster rates of flow. I am not a big fan of fast rates of flow. I'm all about pressures and controlled rates of flow. Again, my style, not saying it's right, it just works for me. A separate solution can be prepared for injection of the head and the face. So this is ideal for bodies with facial trauma. Okay, this is absolutely ideal with bodies for facial trauma because you can use a very strong solution with a minimum quantity to secure preservation and prevent swelling. You should also use this in bodies when facial distension is anticipated. Delayed embalming, refrigerated, frozen, bodies exhibiting early signs of decomp are all examples where the face can easily swell during injection. Now, another category that's not here is sudden trauma. Okay? So if you have a vehicular accident, you have someone that was basically hit and then they died. Those type of cases, swelling has not had a chance to happen. When you start injecting, problems could happen. So yes, it is a situation where facial distension is anticipated, but you may say, hey, this person died in a car accident. They didn't really get beat up in the face too bad. This should be a pretty good case. Chances are pretty good you should err on the side of caution, do a restricted cervical injection so that when you start injecting, you are paying very close attention to what is happening with that face. Because I'm telling you from my experience as an embalmer, you can go from 0 to swollen in less than 7 seconds. And that is not using ridiculous rates of flow. That is not using ridiculously high pressures or a combination thereof of both of those. It is you are being extremely careful and conservative with injection and just simply all that rupture has happened, and now that you're putting fluid in there, it is doing what fluid does when it hits a ruptured area. Also, bodies in which eye enucleation has occurred, the moral of the story here is facial trauma. And again, what they've done here is they just keep copy and pasting the same exact thing about control of strength, amount of solution, pressures, rate of flow, blah, blah, blah. So I am not going to read this every single time. Bodies with generalized edema, it's already swollen, so You're going to probably, you could inject one, we're going to study a little bit later on in the course different ways to deal with edema. And what you can do is you can use one of those techniques in the body, followed by a different technique for the head. Moral of the story, difficult to firm bodies. Again, complicated situation. With many drugs used today, protein levels in the body can be low. Restricted cervical allows you to inject large quantities without over-embalming facial tissues. So you could basically just keep pouring, keep injecting strong solution, larger quantities into the torso and the extremities until you finally get what you're looking for, and then you can work on the head. Bodies with distribution problems, that way you don't push any clots into the head or do any swelling. Bodies with high formaldehyde demand, bodies in which purge is expected, jaundiced bodies. What the moral of the story here is, when should you use restricted cervical injection? On almost every type of example that you saw with multi-point, right? Almost all of these categories match what you should be doing with a multi-point body. Why would you do restricted cervical rather than multi-point? Because it's quicker. Just flat up, because it's quicker. Instead of raising 6 arteries, you're making 2 incisions, raising 2 arteries, and going from there. A restricted cervical can very quickly lead to a 6-point if it needs to go that way. But again, time factor. If I can just make 1 incision, open it up, raise both arteries, do my thing, and start letting it go, especially in a high-volume prep room or a prep center, that might be the reason why you immediately go to RCI every single time. So now, instant tissue fixation, also known as a head or a face freeze. Instant tissue fixation is an embalming technique that combines with restricted cervical injection. It actually is combined with any type of injection, typically multi-point or restricted cervical, rather than 1 point, for reasons we'll explain. Strong solution under high pressure is injected in a burst suppression pattern. A minimum volume of preservative creates maximum firming without tissue swelling. This embalming technique is used primarily for the injection of the head. Other areas can be similarly treated with a limited volume of a very strong hypertonic arterial solution. The moral of the story here is you want to inject very little but very strong. And you can do that anywhere in the body. What was the most common reasons why you would use instant tissue fixation? Early decomposition when facial swelling is anticipated, facial trauma is present, facial tissues must be dried and firm for restorative treatments, facial excisions are necessary, cancers, etc., and re-embalming of the face. So with ITF, this is... There are things that are in this book that I'm just kind of like, why did you do this? And basically what they're explaining here all over again is a restricted cervical. Because that's really what you're doing. You're isolating each one of these arteries, and you're pushing a very strong, very concentrated solution into the head to basically hit it, let it preserve, then you hit it again, and you let it preserve, and you hit it again, and you let it preserve until such time that the tissues themselves are preserved so that they don't swell. Once we get tissue preserved, it will not basically swell. And that is the goal here, that we put in such a strong solution that immediately it starts to react. And so each time we do it, we push it a little bit further, a little bit further, a little bit further until we get it completely done. So a very strong arterial solution is prepared, typically waterless. Typically waterless. You are pouring nothing but the bottle of preservative, probably a co-injection fluid, maybe a water corrective, but really it's a very, very small amount. Insert an arterial tube into the left common carotid artery. Select large diameter arterial tubes as well as the arteries will allow. And then away you go. It says turn the machine on with rate of flow valve closed. Set the pressure at 20 pounds per square inch. And then Open the rate of flow valve a full turn, immediately turn it off or open, and close the stopcock to create the burst suppression method of injection. The moral of the story here is you are squirting at low pressures, relatively low pressures, 20 psi is relatively low, a burst of this solution in the head and you're immediately stopping it. So this is where a stopcock becomes extremely useful. So here we have a Y tube. Okay, here we have a Y tube. Again, we'll go back to full screen here for a second. So when your valves are perpendicular, they are closed. So what I would do is I would have my embalming machine coming into my Y tube. I would have this at 20 pounds per square inch. Now, what I can do with a stopcock is I can turn my rate of flow completely open. Okay, completely open. And then to simulate the spurt, what I can do is open, close, open, close, open, close. Maybe go to the other side, open, close, open, close. And every time I open this, we're getting a huge spurt out and I immediately stop it. This should arrest heavy swelling very quickly. So chemicals you're going to be using for this are typically your fast firming chemicals, Intrafiant, Trauma Care, Power Tone Vivid, chemicals in that category, because you're not here to play games. You're here to get this preserved as quickly as possible with as little as possible. And then you just keep doing this process until you're done. Only a minimum volume of solution is needed because of its strength. The dye will indicate the presence of the solution in the tissues. In addition, dye will help prevent graying of the tissues because you're not going to be pushing a lot of the of any blood that may be in capillary spaces or whatnot out. Normally, we want to displace as much of that as possible. We're not really getting that with instant tissue fixation. We're getting what we need in there to prevent it from swelling. And then we're hoping for the best, and you're likely using this technique. It's almost always on trauma. You're going to be using heavy cosmetics. And then you repeat the cycle for the other side of the head. So deep breath. Let's talk about drainage. Okay, let's talk about drainage. Drainage is brought about by displacement. As the arterial solution fills the vascular system, the contents of the vascular system are displaced. There are typically 5 to 6 quarts of blood in the vascular system of a 160-pound body, and this accounts for approximately 8% of body weight. So there's two ways that this question could be asked. What is the number of quarts of blood that could be found in an average-sized body? 160 is about average. Or this could be a computational problem. You are given a 300-pound body. How many quarts of blood could be encountered? And what they would require you to do is multiply 8% by the body weight of 300%, getting to about 24 quarts, something along those lines. Not saying everyone's going to do that, just saying that there's two numbers here that are important, 8% of body weight, 5 to 6 quarts typically in a human body. You know some ways that can be used against you now. At death, there is generally a wave contraction of the arterial system. This contraction forces the greatest volume of blood into the capillary system and the venous portions of the blood vascular system. It has been estimated that after death, 85% of the blood is found in the capillaries, 10% in the veins, and 5% in the arteries. The vast majority of blood is found in the capillaries. Why is this important? Paths of least resistance. We have to fill as much of the body as possible, okay, the 15% before it starts pushing into the 85%. As long as there is space in the 5%, it will want to flow there because it's empty and there's nothing to push out of the way. You are preservative solution. Okay, you are preservative solution, and you go to your favorite place to shop, retail big box store, the one with the blue sign and the big yellow smiley face. You're walking up to the cashiers. Some of you might just go right over to self-checkout. Why? Because they got 2 cashiers open, and you see that there's 16 self-checkouts, 14 of which are open and ready for you. So your choice is wait in a line of 8 to 10 people, or just go do it yourself and get out of Dodge. What'd you do? You took the path of least resistance. Right? You took the path of least resistance. As a blood cell, you see that the capillaries are full, or you can go down this other route. What are you going to do? You're going to go down the other route every single time. Amounts of blood in the vascular system vary depending on cause and manner of death. In addition, blood and fluid are going to gravitate into dependent body regions over time, again, post-mortem hypostasis. We also have lymphatic circulation. The lymphatic vessels originate as blind end tubes called lymph capillaries. These tubes are located in the spaces between the cells. The lymph capillaries are larger and more permeable than the blood capillaries. They converge to form lymph channels called the lymphatics. The lymphatics have valves similar to those of veins and contain lymph nodes along their routes. Their fluid eventually enters into the blood vascular system by flowing into the thoracic and right lymphatic ducts. The thoracic duct empties lymph into the junction of the left subclavian vein and the left internal jugular vein. The lymph from the right lymphatic channel empties into the junction of the right subclavian vein and the right internal jugular vein. In life, the lymph is composed of the fluids that pass from the blood through the walls of the capillaries. Here it is called tissue or interstitial fluid. More fluid enters the interstitial spaces from the blood than is directly reabsorbed back into the bloodstream by the capillaries. This excess fluid is drained by the lymph system. Once the interstitial fluid enters the lymph capillaries, it is called lymph. At time of death, these lymph channels can be the site of large numbers of microbes. The lymph system is part of the defense system for protecting the body from pathological microbes. Embalming solution will diffuse from the interstitial spaces into the lymph channels. Massage and manipulation of the body during injection combined with the use of restricted drainage help to move embalming fluid throughout the lymph system. Embalming solution can be diffused through the lymphatics in the following order, and this is an important order to memorize. Lymphatic capillaries to vessels, nodes back to vessels, trunk to the subclavian vein. Blah, blah, blah. What is all this crap, Professor Finn? Super simple. Okay? This is a capillary. This is your interstitial spaces where all your cells are, right? Where all your cells are. And what we know is as you are injecting in life, or as you are injecting, we are pushing stuff out into the cell spaces from the capillaries, right? That lawn sprinkler effect. And what we just saw in the last couple of slides is the fluid that's in here, okay, the fluid that is in here has a hard time going against the lawn sprinkler. If fluid is coming out, it's hard to push against that to get back in here to come out as drainage, isn't it? And if we had nowhere else to go, this could be a problem because we just keep swelling until we burst. So what our body actually has is our body has drain portals on the other side called the lymph system, the lymphatic system. So what ends up happening is as we are injecting, our preservative is coming in, right? It's flowing in through here. And what it also then does is it goes into the lymph. And at the same time, displacement, the interstitial fluid is flowing into the lymph system. So what we're having is we're having this pass-through of everything. And when it gets into here, It then flows in the one direction it can because it's like veins, and there are valves, all the way back up into your chest, where it finally dumps into your venous system so it can get recirculated and it exits the body as drainage. Your lymph system literally is the exit only for your cell spaces. Drainage is composed of blood and blood clots, interstitial lymphatic fluid, and embalming solution. Remember, half of what we inject, we anticipate comes out as drainage. As arterial solution flows into the capillary, a portion of the solution passes through the walls of the capillary and is retained by the body. The retained preservative is the portion of the embalming solution that actually does the work. Some of the embalming solution moves through the capillaries into the venules and veins and exits as part of drainage. So what's happening there, since I have this on blue, whoops, didn't want to do that. Is we have our artery, we have our vein, we have our arteriole, we have our venule, and down here we have our capillary. This is what allows fluid to get into the tissue spaces. Now, rough diagram, not intended to be scientifically accurate. You get the idea. That's the point of this. And what happens is, as the stuff comes flooding in through injection, it has two options. It can take the pressure release valve, which is the arteriole, and then pop into the vein and immediately comes out as drainage. No preservation happens. It just basically is preserving the artery. It's preserving the vein wall. That's it. Then we have the stuff that actually continues on into the capillary. And when it does that, it actually goes into the tissue spaces. Some of that continues on into a venule and again comes out as drainage. Once it gets into the capillaries and into the tissue spaces, we then have a lymph system which then also delivers from the opposite end of the tissue spaces the fluid that has been injected, in the interstitial fluid and the lymphatic fluid. Inevitably, both of these things end up connecting in the upper chest, where it's going to come out as drainage. It has been estimated that 50% or more of the drainage taken during embalming is actually embalming solution. The color and consistency of the drainage changes during arterial injection of the body. During injection of the first gallon of embalming solution, drainage contains more blood than subsequent injections. We're displacing blood, right? It's going to come out first. And as time progresses, we're getting less blood out because we've gotten blood out. As the blood in the vascular system is gradually displaced and replaced with embalming solution, the drainage lightens in color and becomes thinner until it is a majority of solution. The initial drainage is the most dangerous because it is mostly blood. All drainage should be carefully controlled and splashing should be avoided. Embalming the body raised on body bridges allows drainage to fall onto the prep table where it can be washed into the sanitary sewer system. There's also a technique called closed drainage. A clear plastic hose is attached to a drain tube and the open end placed in a drain. And this does not expose the embalmer to the contents of the drainage. Now, back to full screen. I have here a large drain tube. Basically, I think this is what would be classified as an iliac drain tube. And what they're suggesting is you would attach a piece of hose. To my drain tube, which this hose is slightly too small. Slightly too small. So any drainage would come out of this through my hose and into my drain, never comes into contact with the body, doesn't come into contact with me. Now, how frequently are you going to encounter something like that? That literally depends on your preceptor. I'm looking for my drainage forceps, and for some reason I just can't find them right now. Here is something more along the lines of a standard size drain tube. You can see it's much smaller than the other, and that fits quite nicely into my drain. So I'll have to look for my drainage forceps, because that's really weird they're not in here with the rest of my embalming tools. Oh, there we go. So here are my angular spring forceps. It is impossible to attach a hose to these. So if you use angular spring forceps, which I greatly prefer angular spring forceps, you're not going to be able to do closed drainage this way. Dehydration can result when too much interstitial fluid is removed. In bodies with skeletal edema, this is how the edema is removed from the tissue spaces. Bacteria and microbial agents and their products have entered the blood vascular system before or after death are also removed in the drainage. In bodies with skeletal edema, the edematous fluid may be part of the drainage. Venous coagula are included in the contents of the drainage. Several types of clotted material present in the drainage. However, all clotted material come from the veins or from a heart chamber. It is impossible for arterial coagula to pass through the capillary beds and enter the venous side of the circulatory system. In the direction of blood flow, the pipes do nothing but get smaller. When something too big gets to a smaller space and blocks that hole, it goes no further. Anything that comes out regarding clots is on the venous side where the pipes do nothing but get bigger. The following coagula can be identified. Post-mortem coagula. These coagula are not actual clots, but simply blood inclusions that have congealed and stuck together. They can be large and dark. Postmortem clots are multicolored. The bottom portion of the clot is dark, for it was formed by blood cells that gravitated to the dependent part of a vessel. The clear layer on top is the fibrin. Antemortem clots, such as thromboses, form in layers. A layer of platelets, a layer of fibrin, followed by another layer of platelets, and so on. The viscosity of blood can vary depending on the cause of death, the time between death and embalming. As the body gradually dehydrates after death, the viscosity of the blood increases. Bodies that have been refrigerated for very short periods after death have been administered anticoagulant drugs such as heparin or dicumarol, or have died from carbon monoxide poisoning, exhibit low blood viscosity. Very, very important. The stuff that keeps the blood liquid. Carbon monoxide poisoning, anticoagulants, or refrigeration shortly after death. The volume of drainage is not equal to the volume of embalming solution injected. Okay, the volume of drainage is not equal to the volume of embalming solution injected. A large portion of the blood vascular system, particularly the arteries, is empty at death. This area must be filled, which accounts for the delay often noted between the start of injection and the start of drainage. At the conclusion of embalming, the arterial system is filled. Some of the injected solution is found in the capillaries and the veins, and some is passed through the capillaries to be retained by the tissues and the cells. In some bodies, there will be little or no drainage. As long as the solution is distributing and there is no swelling or discolorations in the tissue, drainage need not be a concern. If you are not getting any drainage, and you see no swelling in the tissues, no swelling in the abdomen, and everything is going fine, everything quite literally is going fine. Be concerned, but don't lose your mind over it. Often in bodies in which hemorrhage into the digestive tract or abdominal cavity occurred prior to death, there may be a gradual swelling of the abdomen as the arterial solution is injected because some of the drainage in solution will fill the digestive tract or abdominal cavity. This drainage can be removed with a trocar. The moral of the story here, okay, is if you're still seeing signs of distribution, clearing of discolorations, dye rising to the surface, you're still getting the work done, even though the tummy is swelling. So you might have to take some steps to reduce that by puncturing with the trocar and draining, but you still have something going on. You should start getting worried because you probably have to go to a multi-point at some point just because you might not get what you need in some of those areas, so you're going to have to inject those areas directly. Hemorrhage into the stomach, esophagus, or lung tissues can result in purge during injection. The purge will take the form of drainage. It is actually possible to drain from the mouth if a stomach ulcer has ruptured large veins, and aspiration will later remove these fluids. Some medications can cause gastrointestinal bleeding. If the bleeding was intense, a major portion of the drainage may flow into the intestinal tract during arterial injection. The bodies just described may demonstrate two forms of drainage, internal into a cavity or hollow organ and external through the drainage tube or exit as purge. Good drainage may be expected under the following conditions. Not always, but can be expected. The interval between death and prep is short. The body retains some heat. The body shows early evidence of livor mortis, indicating the blood has a low viscosity and can easily be removed. Death was not the result of a febrile disease or a bloodstream infection because you'll have extra stuff in the blood making it more viscous. Skeletal edema is present. More water in the body, the more fluid there is. More fluid there is, the more it's going to flow out. The body is jaundiced because typically when the body has jaundice, it is retaining water. Your body is trying to dilute the concentration of the wrong stuff. The person has been treated with blood thinners or anticoagulants, resulting in low blood viscosity. The body was refrigerated shortly after death, but not for a long period, and death was due to carbon monoxide poisoning. The bodies used for dissection are often embalmed but not drained, and most are swollen to the point where they could not be viewed for funeral purposes. That is true. At one of the institutions I've worked at, I've seen the version of anatomical embalming they want, and they are swelled beyond recognition. Bodies dead for long periods of time can be slowly embalmed without draining and are often suitable for viewing. Drainage is taken for a number of reasons: to make room for arterial solution, to reduce secondary dilution of the arterial fluid. The more stuff that's in there, the more stuff that our arterial preservative is going to react with. And if it's reacting with blood, it's not reacting with cellular proteins. To remove intravascular blood discolorations, to remove a tissue that rapidly decomposes, to remove an element that speeds decomposition, to remove bacteria that is present in the blood, to prevent discolorations, and to reduce swollen tissues. If a primary purpose for drainage must be stated, it would be that the drainage makes room for the arterial solution so it can be evenly distributed to all tissues of the body with a minimum amount of distension. Here is your primary purpose for drainage. So the center of drainage in the dead human body is the right atrium of the heart. The superior vena cava returns blood to this chamber from the head and upper extremities, and the inferior vena cava returns blood from everywhere else. After death, the blood in the right atrium frequently congeals. This condition warrants drainage from the right internal jugular vein, where an instrument, such as angular spring forceps, can be placed directly into the right atrium to fragment this coagulum. Drainage instruments are always directed towards the heart. So above and below heart drainage. Some embalmers use two locations for drainage. A second drainage point is often used when the femoral vein is used as the beginning injection and drainage point. The right internal jugular vein should be raised and opened as a secondary drainage site. The primary drainage site is the location where drainage is first taken. Plain and simple. If they're giving you a word problem, say, where does your primary drainage site? You're looking for the place you first poked a hole to get drainage out. It's literally that simple. Don't overthink it. In the unautopsied body, the most commonly used for drainage are the right internal jugular vein, the femoral vein, the external iliac vein. The axillary and basilic veins can be used, but their small size and need to extend the arm make these veins an impractical choice. What are we seeing here? Same as injection sites. Neck first, followed by legs, followed by armpits. As long as you know what the names are for the structures in those locations, it's the same thing. Neck first, legs, hips second, armpit/upper arm last. Any vein can be used for drainage, whether it is large or small, or on the right or left side of the body. Veins will leak nonstop. They are impractical the smaller they are. One of the common things that are asked is which of the veins following are suitable for injection. And you might not have legs, hips, neck, or armpits. Your goal there is to choose the largest of those veins. So you'll have to think about where that vein is located and how much traffic it gets, and that's going to be the one that you use, the largest of that choice. In unusual circumstances, even the external jugular vein can be used if the internal jugular vein is obstructed by a cancerous growth or a large attached thrombosis. A broken vein can still be used as a drainage site. If an instrument such as angular forceps cannot be inserted, a grooved director may be used. Following injection, the area can be dried and the ends of the broken vein are ligated. Back to full screen. What you see here is a grooved director. And all they are suggesting is that you're going to take this, put this into the broken area of the vein, and then you are going to utilize some method by which to put in your drainage instrument. So you could use something like a groove director, or my favorite instrument on earth is this combination tool that has a guide at the other end of it. So what I might do on a complicated situation is get this inside my vein, use this to kind of form my path, and then come in with my spring forceps, angular spring forceps, and get that open. I could do the same exact thing with a drain tube. So here I have a smaller drain tube, and you can see that this also fits relatively nice right inside that vein expander. Should a vein tear while it is being raised, the following steps can be taken to attempt to place an instrument if the portion of the vein leading in the portion of the vein leading to the heart. Force as much blood from the vein as possible. Why? Because it will just continue to leak and obscure your sight. Observe where the blood is seeping from the broken portion of the vein. Clamp an edge of the wall of the broken vein with a small serrated or rat-tooth hemostat, or place the hemostat across the entire broken portion of the vein. Gently insert a drainage device towards the heart. If the vein has been torn into two pieces, do not remove the hemostat. After embalming, ligate. All they're basically saying is use whatever device you want. In this case, we're going to use some locking forceps. Back to full screen. And you'll see that these have rubber protection on the top just because the fact makes it easier to see, especially on camera. You're going to grab the edge of it with your locking forceps, and then you're going to try to sneak what you need in there while this is being held, especially if you have a really broken artery. Now, What I suggest, me personally, there's no difference between the locking forceps and the locking hemostat, is you use your arterial hemostats to do this. The reason is there is a lot more real estate. I know with the rubber tips on, they look about the same size, but they are not. These are much thinner. This gives you a lot more grip. So when you lock this in place, it's going to hold it a lot better for you. That is just my recommendation. You may do with it what you will. But either way, the story remains the same. Grab it and hold on to it with something. The internal jugular vein is the most valuable drainage point. It is the largest systemic vein that can be raised in the unautopsied body. The right internal jugular vein leads directly into the right atrium of the heart. Should there be a complication with the right internal jugular vein, the left can be used, but note that the vein turns to the right, often making insertion of a drainage instrument difficult. Moral of the story, don't force it. You're likely not going to get that into the heart, so just take your win and get what you can in there. A different method involves piercing the right side of the heart with a trocar and guiding the tip of the instrument directly into the right atrium. This is known as direct heart drainage or a heart tap. Direct heart drainage was practiced at the residence of the deceased. Today, direct drainage from the right atrium is recommended for infectious cases to eliminate contact with blood and bodily fluids. Now, you can buy a heart tap trocar. Let's jump back to the screen real quick. There's the slide that I missed. Now, the only trocar that I have here is my full-size slaughter trocar. And you can see, go back to full screen real quick, that this is really large to try to stuff into the body. Now, you can absolutely use this. No ifs, ands, or buts. This is perfectly acceptable. But they do have a smaller one that is intended only for heart taps or direct heart drainage. And the goal here is to pop it into the heart and start taking drainage. Now, with something like that, there are a couple of things that you have to do in preparation for this. So the first is, if you're doing this, you might want to just run a tube from the trocar down into the drain so that nothing's getting on the table, making your life messy. This is also really useful if you are you have a vein blockage that's not really solving itself. You can just open the heart basically and take it right from there, and that should get you some changes. So here's the process for this, and you really have to follow the process for this or it doesn't work. First, you can inject 1/2 to 1 full gallon of arterial solution against closed drainage. Fancy way of saying, you can literally put in a gallon of arterial solution before you really have to worry about drainage. Because remember, we have a lot of space to fill. Connect the trocar to clear tubing on the aspirator and engage the aspirator, i.e. turn it on, and set it to low or moderate suction. Insert the trocar through the abdominal wall at the standard point of entry for cavity treatment, 2 inches to the left and 2 inches superior to the umbilicus, 2 inches up and over from your belly button. Direct the trocar into the mediastinum area and intersect a line extending from the lobe of the right ear to the left anterior superior iliac spine. We're going to see this in an upcoming slide. Guide the tip of the trocar into the right atrium of the heart and stop. The first appearance of drainage in the tubing indicates proper positioning of the trocar tip. Then discontinue operation of the aspirator and drainage will continue by gravity. So here's what they're talking about. Is you are going to draw a line between that right earlobe down to the hip, right? You're going to put your trocar in and you're going to try to bisect that line. You're going to try to bisect that line. Your heart has to be swollen so that when your tip goes in, it will puncture and immediately do its thing. Now, Mastery of this technique is critical to prevent the tip of the trocar from breaching the heart muscle. In doing so, you've put a big hole in the water main, and now you're going to have to do a 6-point injection because you're not going to be able to build pressure anymore. So what is a great way to practice this? Well, you do this point of entry technique when you start aspiration every single time. So when you are done your embalming and you're about to go ahead and aspirate the cavities, you imagine your line, you put in your trocar, you get it where you want, you pop it into place. Do this 30, 40, 50, 60, 70 times. By the time you get to that 70th, 80th case, you should be able to do this almost in your sleep. So there's a gentleman in Florida that used to be my Dodge rep, a guy by the name of Jay Rhodes, a long time member of the Dodge Chemical Company, one of the fixtures of southeastern Florida, that when he was going through his apprenticeship, his family used to own a huge popular funeral homes in the St. Petersburg, Tampa Bay area. This is the way he was trained. And this guy, I'm telling you, Jay can drop a heart tap without even thinking it. Very, very talented embalmer. Proud to say that he is an alumnus of my former institution, and proud to call him a friend and colleague. So I was always impressed how he just walks up and pops it. And people are really scared of this technique. I'm really scared of this technique. And I suppose if I get another 70 or 80 cases under my belt, that I'd probably be able to get it done. But Jay just had a talent for this. I never saw him do anything different. Or he could demonstrate this at a moment's notice. He would do other methods of drainage as well, especially when he was doing guest clinical work in my teaching lab. But just his ability to drop a heart tap was unparalleled, man. So instrumentation, we've already shown you some of the instrumentation. Drain tubes, angular spring forceps. Always insert these things to or towards the heart. One thing I will tell you that's just phenomenal here is some embalmers do lubricate these, and I will tell you that if I'm using a drain tube, I am absolutely putting lubricant on there in the form of massage cream, or my preferred product to use is stone oil. I think stone oil is a superior product just overall. Drain tubes contain an internal mechanism called a stirring rod, which can be lubricated with massage cream. That is a polite way of saying you should do that, because that will keep these things from rusting out and just make it super easy to clean. After each use, drain tube should be disassembled, flushed with water, clean, and disinfected. Let's go back to full screen. So here we have one with a plastic handle. Here's one that's all stainless steel. They work identical. Okay, they work identical. So one thing that you see here is I have this one unscrewed so that you could actually access the interior workings. You could also lubricate this with massage cream. Then we'll close that on up, and you can see that it's closed. It's at this point we have this closed. You're not really going to get a whole lot in there. You might get some collateral leakage through the open tip there, but it's a very, very small space. If I pull this back farther, I am now completely blocked the interior. This thing is absolutely closed. There is nothing that is going to be coming out my drain. And then if I pull it all the way to the back, that tip is now embedded back here, and I have free and open aperture to have my product or have my drainage come out the drain port. So moral of the story, if you're using one of these, you either have it open or you have it closed. Make sure you know what position you're in. The longer the back end, the more likely it's open. And there's really no difference in how these work. You'll see that this has slots, this has holes. Which one is more beneficial? I really can't tell you. I'm sure someone will be happy to drop that in the comments below saying which one is superior. I'm just going to agree and say amen, brother. The stirring rods on these are relatively blunt. You can see that this one is a bit more angular, and I've seen some of the older ones that actually have like a little hook on the end to help break up clots. Me personally, I am not a huge fan of using drain tubes. I greatly prefer angular spring forceps. Here's your grooved director. I've shown you that before. You could actually use this as a drainage device. So if you, especially with small children, infants, if you can't use a drain tube, you could use something like this to open it up and just leave it expanded. This typically is just used as a guide though. Once you get your drainage instrument in, you would take this out and you're done with it. But again, it can be self-sufficient, especially on smaller veins. Many times a drain tube cannot be fully inserted into the vein, and it should not be forced. As long as a portion of the tube can be inserted, it will keep the vein expanded. Changing the position of the tube in the vein often assists with drainage. Fancy way of saying that you don't need to have the whole thing in there. The goal of this is to create an opening in your vein, okay, on a drain tube. And as long as it's embedded, as long as this portion here is in there, this first about 2 inches, you're good. Okay, you're good. Clamp right back here, and this will keep your vein expanded to some level so that stuff comes out. That's the benefit of this, that the vein cannot collapse. The disadvantage is you're never going to get that hole more open than what you see here, because that's the limitation of this device. Hence, why I don't like using them. Whereas if I have something like a angular spring forceps, I can really get that vein open. Tubes should be tied into a vein, but loosely enough so that their position can be changed, and clearly the drain tubes comes in different sizes. Internal jugular vein tubes are very large in diameter and short in length. Axillary drain tubes are very long and slightly curved. A variety of drain tubes are made for the femoral vein. They come in a wide range of diameters and lengths. One type of iliac drain tube is designed to be inserted into the external iliac vein, and the tip of the tube reaches into the right atrium of the heart. They are approximately 20 inches in length and made of plastic, metal, or rubber. I have never used one of these. I've never seen one in a lab. If you use one of these, hey, feel free to drop that in the comments below, just so I can see how prolific maybe you use it. Doesn't mean you have to use it. If you've seen your preceptors or your embalming instructors use it, I just like to know where this is being used. Drain tubes with very small diameters are also available for embalming autopsied infants. Angular spring forceps can be used to assist drainage from any vein. The angular spring forceps is convenient to use for drainage from the right internal jugular vein. It does not block from the left innominate, right subclavian, or upper portion of the right internal jugular. If you use a drain tube, you might actually block those from pulling back in because you've blocked their holes. With these, you are, for the most part, allowing things to stay open. And again, there's no real big difference between the two of these. All they are angular spring forceps. This one's a bit thicker, looks a bit beefier, but it's also got a much deeper groove on the inside. I'm not really going to blow these up. You can find these fairly convenient on the internet. Really, an angular spring forceps is just an angular spring forceps. Provides a wide opening for the passage of coagula, and above all else, this allows you to grab coagula. So you can grab it, you can pull it, and yank it right out. And you can position the head of the forceps away from the face so you don't mark tissue. With a drain tube, depending on how far you have it in or that particular body, it may be brushing up against some place that you don't want, and it'll mark the face. Here's a great example of how you can block yourself. So you can see here that you have your drain tube, and it's completely occluding this side vein. That means nothing can come out of this. It's just going to sit here and build with no way to fix it. So realistically, a way to fix that would be to pull this back some so that there's space coming out, or get maybe this open space here farther back so that some of that can come out. Many embalmers use a combination of drainage methods. They might begin the injection using continuous drainage, then restrict, or use intermittent after discoloration's clear. Let's talk about those three basic types of drainage. So in alternate drainage, The arterial solution is never injected while drainage is being taken. A quart or two of the arterial solution is injected, then the arterial injection is stopped and venous drainage commences. So you are injecting, you stop, you let it build pressure, and then you open your drainage and it starts coming out. When I was teaching physically in class, what I would do is say, put your arms out and alternate. One of these is injection, one of these is drainage, right? So if you are an alternate, one hand is moving and then the other hand is moving. You are never doing both at the same exact time. This is allowed to continue until drainage subsides. Once you don't have any pressure left, you close the drainage instrument, you start back up until you have injected the entire amount and the embalming is completed. Because 1 or 2 quarts of fluid is constantly injected into a confined system, it is believed that you get a more uniform pressure and more complete distribution. Fluid diffusion should be enhanced and pressure filtration is increased. This method increases preparation time and care must be taken to avoid distension. So it takes longer and you have an increased risk of swelling. This is one of the arguments why people do not use this. Concurrent or continuous drainage. Injection and drainage are allowed to proceed at the same exact time throughout the embalming. Because of the open drainage, achieving a uniform pressure can be difficult. Getting saturation can be complicated. So with concurrent, your arms are moving at the same exact time. You're injecting and draining the entire time. So you're never really able to build up a large level of pressure because the hole is always open. This is the most common method that people apparently use, even though it might be the least efficient. Clots may not be dislodged when the concurrent method is used. Fluid will follow the path of least resistance. You've poked a hole, it's going to come towards that direction. So you may lose more embalming solution to the drainage than you would with other methods. This method can also dehydrate and wrinkle the body tissues. It has value in the preparation of bodies with high moisture content. So if you have edema, continuous drainage is actually recommended because you want to get as much of that water out as possible. Intermittent is a blend of the two. The injection of the embalming solution continues throughout the embalming and the drainage is shut off for select short periods. Some embalmers stop drainage until a particular amount of solution is injected, 1 or 2 quarts. Others stop drainage until surface veins are raised. Whatever. The moral of the story here is as you are injecting, every so often, the other arm kicks in. And then you stop and your injection never stops. You start draining at some point and then it just stops. It is important that surface intravascular blood discolorations clear before intermittent drainage is begun. The method is less time-consuming than the alternate method, encourages fluid distribution and pressure filtration, helps to prevent short-circuiting and its loss and embalming solution loss to drainage, and promotes retention of the solution by the tissues. Intermittent drainage helps the body retain fluid, which decreases the likelihood of dehydration, and is recommended when colloidal fluids such as humectants or restorative fluids are used. Very important thing there. Is recommended when colloidal fluids such as humectants or restorative fluids are used to slightly distend emaciated tissues. Yes, you're reading that correctly. What you're doing is you are taking very emaciated, very, very thin tissues and actually encouraging a little bit of swelling to retain some normal facial appearance. Now, there are some very strong opinions on whether you should use swelling to simulate that. I'm not going to step into that show on this particular lecture. I am simply saying that discussion is out there, and one of the ways that you can treat emaciation is by utilizing a little bit of controlled swelling. So techniques for improving drainage. Pre-embalming techniques include the following. Selection of a large vein. Preference is generally the internal jugular or the femoral or external iliac vein. Selection of a large drainage instrument, an angular spring forceps or a large drain tube. Injection of a pre-injection fluid. Follow the manufacturer's dilution of the chemical and volume of the chemical injected. If a pre-injection chemical is not used, a mild arterial solution can be injected to clear blood discolorations and establish circulation. So remember, in a pre-injection, we have no preservative value. Okay, no preservative value. If we're using a mild arterial solution, that usually means a 1.5% or lighter solution. It has some preservative value, but it's not enough to get the job done. We're going to want to chase it with something stronger. But for what we're doing, it's good enough to push all the nasty stuff that we don't want out, while also adding a little bit of something to begin that preservation response. Removal of extravascular pressure such as gas and fluids in the abdomen. The following techniques are included during injection. Use of drainage devices to fragment clots. Use of massage and pressure applied over the heart and or liver to move venous clots. Increase in the rate of solution injection or increase in the pressure of the solution being injected. I am always a fan of increasing pressures over increasing rates of flow. If you have 300 pounds per square inch, but you have a proper rate of flow, you can get some really amazing results. If you have a high rate of flow, even at a low pressure, you can still have swelling lickety-split. Use intermittent and alternate forms of drainage techniques. And if you have to, don't be afraid to raise another site. So it takes more time. Remember what I opened this lecture with. Just because it takes more time doesn't mean it's not the right thing to do. And a lot of people focus on the efficiency versus anything else. The initial drainage, also called the first drainage, presents the greatest risk to the embalmer when the cause of death was due to a bloodborne pathogen. At present, OSHA permits bulk blood, suction, and aspirated fluids to be carefully drained into a sanitary sewer system. Drainage from embalming consists of blood, interstitial fluids, lymph, and arterial solution. The arterial solution will to some degree sanitize the blood and body fluids present in the drainage. Upon entering the sanitary sewer system, drainage is further diluted by running and flushing water. The embalmer can minimize contact with blood drainage by using a drain tube instead of angular spring forceps. Attach the device to a generous length of tubing that reaches the drain of the flush sink or other basin. And then closed drainage. This technique is recommended for embalming bodies with a highly infectious or contagious disease. A strong arterial solution, typically waterless, is injected at a very slow rate of flow without taking any drainage. Aspiration should be delayed. If you're using closed drainage, aspiration should be delayed as long as possible to allow the embalming solution to diffuse to all regions of the body. Now, this concludes the lecture. Just in closing, real quick, want to jump back to something we just looked at, which was the flushing of blood down the sanitary sewer system. A lot of people, especially some townships, you jump on the internet and you look for some news articles, officials express outrage that embalmers are dumping blood and these infectious materials into the sewer system. And the reality is, one, embalming is on the decline. Maybe we're putting 2 quarts, 3 quarts of biological material into the system in addition to the formaldehyde. The amount of solid waste, fecal waste, the amount of urine that a township puts into its sewer system far exceeds anything that funeral homes are probably doing in the same area. And the truth is, science matters. Urine has ammonia in it. And we've already learned in this course that ammonia will neutralize formaldehyde. So between the fact that some blood is being rinsed or being discarded into the sewer system, it is then being mixed with the biological wastes of human beings, the impact of that material really is probably negligible when it comes to everything else that is found in that sewer system that could actually harm and kill you. So I find arguments where, oh my God, we're flushing this stuff, to be very weak in regards to the threat it presents to human communities. That's just my soapbox. I want to tie that on here because I know a lot of people talk about that point as they become more environmentally conscious. Let's just be honest that we use sanitary sewer systems for a reason. Embalming is on the decline. We're not pouring tons of blood in there. And with everything else that's in the sewer system, that literally is the least of your worries. So folks, this is Professor Finn signing off. We will see you next video.